Don't worry, I'm okay.
So this morning I have Dr. Paula Brown for us. She is my friend and colleague from the artist formerly known as Hudson Medical Group, now Mount Kisco Medical Group. She did her fellowship training in Buffalo, where she actually spent about half of her training doing pediatric allergy immunology. And so I just wanted to introduce her as another great resource added to our community. So take it away, Paula.
Hi. Morning.
I want the front lights down, so.
It's whatever you want. Yeah, you guys won't fall asleep, right? No. Okay, cool. So as Jill was saying, yes, I did my allergy training, two-year training session in Buffalo under the tutelage of my chief, Dr. Mark Ballo, who's a well-renowned pediatric allergist and immunologist, and I currently see both peds and adult patients. I think I'm seeing more peds this time. I think they like the fact that when we do skin testing, we put the computer on and they can watch YouTube for 15 minutes. So it's kind of hard to kick them out of the office for some time. But I think what I wanted to do today was discuss some common questions about food allergies, because food allergies is becoming a little bit of an issue, and some parents really don't know how to tackle these. We don't know what to give them the right answer. So I just wanted to go over that. I unfortunately have absolutely nothing to disclose. Okay, so one of the common questions we get is, what is a food allergy versus a sensitivity or intolerance? And that actually has to do with the immune system. If the immune system produces a response against the food or spice or something, we do classify that as a food allergy. And that response could be the traditional IgE-mediated response. It could be a cell-mediated response. It could be a combination of the two. Versus if a food gives like a symptom of just an adverse reaction, such as enzyme deficiency and lactose intolerance, or shakiness when you take too much caffeine, that's defined as a food intolerance. Or if you eat bad shellfish and something. Okay, well, good. Okay. Yes. So, I was saying before, the immune system can produce several types of reactions against food, and I think we're very familiar with the common IgE-mediated food reactions, where if someone has the food, they could get urticaria, angioedema, GI symptoms, and then of course we get the nervous about the anaphylaxis. There's also this disease entity under the IgE-mediated category called food-dependent exercise-induced anaphylaxis, which we'll discuss in a couple slides later. But there's also this really new, interesting disease entity where you actually can have delayed food allergies to meat products, and that's really interesting. I'll discuss that in a minute. Then we have the non-IgE cell-mediated diseases, such as celiac disease, FPI, and then we have the combination of the two that's commonly seen in eosinophilic esophagitis, or atopic dermatitis, and I'm going to talk about that too. So I want to really focus more on the IgE-mediated diseases, but I'm going to touch about eczema because that's a big question with food allergies.
Or can you speak a little louder?
Oh, sorry. Oh, I'm sorry. Okay, you could. Yeah, I'll walk closer. No worries. Okay. So a lot of the times people are asking, what the heck is going on with food allergies? And allergies in general, it seems like everyone is allergic to something. And it looks like there is true. There might be an increase in allergies, not in just the U.S., but the world itself. Specific prevalence studies are hard to obtain because of many factors with studies. Who's defining what a food allergy is? Is it the parent? Is it the patient? How do we define a food allergy? Is it on blood testing, skin testing, oral food challenges, food safety, kids or adults, geography? Where are the studies being taken? So prevalence studies are very hard to obtain. The CDC had done some studies looking at food allergies from 1997-99 all the way up to 2011, and based on a single question where parents were asked this question of, did your child present with food allergy symptoms? And that was it. That was the question they asked, and this is where they got the data from. So you can see there is a little bit of a trend upward. When there has been other prevalence studies looking with specific food cause reactions, over here we see that for children it's the milk, egg, peanut, tree nut, which is interesting versus adults where it's more peanut, tree nut, shellfish, fruits, and vegetables. Okay, So what are the risk factors for food allergies? That's a big question itself. Genetics play a huge role with the mother. If there is any first-degree family members that have history of ACT, asthma, and allergies, unfortunately the child is more at risk. Other things such as vitamin D. Vitamin D is a little bit controversial. They've shown that low vitamin D levels in a pregnant mother can be associated with increased obesity, respiratory disease. The method of delivery, if the child is born by a C-section or by a vaginal delivery, we're now showing that a lot of children who are born by a C-section are more prone to food allergies. And this actually leads back to the fact that bacteria is really important for inducing oral tolerance. And bacteria in the vaginal flora, with that exposure, can help prevent that and induce oral tolerance. GI barrier immaturity, when a child is born, the GI tract, as we're well aware, is not well developed. We're also seeing that a lot of patients who are on an antacids for reflux disease, the pH level is changed, and that also could present oxidation in the food and how the immune system recognizes that. There could be issues with the immune system themselves. There's this T cell called T regulatory cell. And that regulatory cell is associated with a disease called IPAX, which stands for immunodysregulation, polyendocrineopathy, enteropathy, X-linked disease. And that was pretty sweet that I said it all in one shot. So we're finding in these patients there's a mutation in TROP3, which is a transcription factor responsible for this. Treg is really important with inducing, with autoimmunity. It helps suppress autoimmunity. So if you have problems with that, you have more evidence of autoimmunity and more evidence of food allergies. Now, the antigen dose and nature, timing of the food introduction, route of antigen exposure, these are all important concepts we have to think about as well. Was the food exposed, through skin? Was it respiratory induced? Was it GI induced? How much did the child get? There are some studies looking at low-dose exposure versus high-dose exposure. How was the food processed? Was it boiled, cooked? All these things can contribute to food allergies, and I'm going to discuss a lot on that side of the column in future slides. Okay, so a lot of the times people ask, okay, I don't know if my kid is having a food allergy. What do we do? What do we look for? Okay, so we're going to just focus on the IgE-mediated symptoms. And the one thing I want to talk about is this disease entity called oral allergy syndrome. I think we're all familiar with it, where basically someone eats a particular food product, they can just get tingling or itching of the mouth, the palate, there can be swelling of the lip or the tongue. There can even be throat angioedema, and usually occurs within a few minutes to after the ingestion. Rarely does it progress to anaphylaxis, but it can occur. And I think the question is why this entity comes up. So we have to realize that there are common proteins that can be found not just in fruits and vegetables, but also between pollen, products from tree products. So I'm going to talk about the birch tree right here. So the birch tree has this allergen called BETV1. BETV1 is part of a family where it's basically helped protect the tree from being eaten by parasites and all that stuff. So BETV1 is not just located in the birch, but it can be found in other fruits and vegetables. For example, apple, cherry. I want you to pay attention to the peanut because it can be found in peanuts, okay, and even in soy. So people who have sensitization to this allergen, not only do they have the respiratory symptoms with the tree pollen, but they can have the oral symptoms with the ingestion of these food products. You see that ragweed as well, ambiate1, can be found, again, in some of those fruits and vegetables. I want to just focus in on the latex. So latex is a product produced by trees, again, for protection purposes. And there are several allergens within latex that can be found in some of these foods, apple, avocado, chestnut, kiwi. So if you have a patient that presents with oral allergy syndrome to certain foods that are like, oh, this could be associated with latex allergy, it's really important to ask them, do they get rashes if their dentists use latex gloves? Because that could help us figure out, oh, there's a latex allergy, and we need to be aware of that as well. Okay, so I just want to go over other symptoms of food allergies. There's this disease entity called food-induced contact urticaria. These are the people, usually for adults, it's food handlers, but for kids, that they're just playing around with raw fruits or vegetables or period, they could just have allergic contact dermatitis and urticaria in the places where they touch the food. We actually see also a big significance of allergic contact dermatitis around their mouth and eyes as well, seen in certain acidic foods, the berries, tomatoes, citrus, and vegetables. But also, again, if they have raw egg or shellfish exposure, they can get those symptoms as well. The good news, again, it rarely becomes a systemic reaction. So these are the common symptoms that can occur after ingestion of the food that you think, okay, this is not good. So look at the cutaneous. I think we're, again, all familiar with the urticaria, the angioedema. That's with the immediate symptoms, delayed symptoms that can happen, minutes to hours after the ingestion could be rashes. Some people with the immediate symptoms, you can have itchy eyes, sneezing, congestion. You can also have, throat clearing as well. The one thing we get concerned about is the lower respiratory symptoms where you can have coughing, wheezing, and chest tightness. GI symptoms, the one thing we're really, really concerned about is vomiting. Repetitive vomiting is a big sign that there might be an anaphylactic reaction going on. And anything that affects the cardiovascular tract, if the blood pressure drops, again, anaphylaxis, I'll talk about a little, is a distributive shock. So your blood vessels vasodilate and your heart rate increases to compensate. So if you feel like they're tachycardic, if they look like they're going to faint, these are signs of a true IgE-mediated food reaction, so we have to be aware of those and treat those accordingly. Food allergies themselves rarely, if ever, cause isolated respiratory or rhinitis symptoms. So if a kid eats something and they just start to sneeze, it's okay. And hopefully that's not the case. And I just want to go over the timing is that the symptoms usually resolve over 4 to 12 hours. Okay. So a big thing is, what is anaphylaxis? I want to go over this in great detail. So our academic board and our state colleague, Simmons, had come up with the definition of anaphylaxis. So anaphylaxis is highly likely with one of the following 3 criteria are met. So the first criteria is acute onset of illness involving the skin, whether it's generalized urticaria, angioedema, swollen lip or tongue, and 2 of the following, where there's any evidence of respiratory compromise, coughing and wheezing, or any evidence of low blood pressure and organ dysfunction secondary to blood pressure, such as collapsing with the hypotonia, syncope, incontinence. So again, for that criteria, you need skin plus respiratory, skin or blood pressure, okay? The second criteria is 2 or more of the following that can occur after exposure to a likely allergen for that patient, minutes to several hours. So here you actually have 4 components. You have the skin, the respiratory, the blood pressure, but here the persistent GI symptoms are the repetitive vomiting, diarrhea, pain. Okay, so you need 2 out of the 4 here. The last criteria is just blood pressure is dropped. Okay, where for infants the low systolic BP or greater than a 30% decrease in the systolic BP, adults similar to that. So what I was taught in my fellowship is usually this. It's kind of 2 organ systems that you think of anaphylaxis, or again, if there's a blood pressure problem. So if you have skin respiratory anaphylaxis, skin GI anaphylaxis, if you just have the blood pressure anaphylaxis, and that's what I was taught, and I think that's a good rule of thumb to think about. Now, food-induced anaphylaxis is actually the leading cause of anaphylaxis treated in the emergency room. Again, symptoms usually occur immediately to 2 hours after the ingestion, and the common symptoms, again, are skin 80 to 90%, respiratory 70%, cardiovascular 40%, GI is up to 45%. So there's this disease entity called food-dependent exercise-induced anaphylaxis, which is kind of interesting. So you have someone they want to get ready for a run, but they want to eat something before, so they have some wheat product or something. Wait a couple hours, and they start going on the treadmill, and all of a sudden they have an anaphylaxis. And that's because of this. And we don't know much about it, but usually it's secondary to eating celery, wheat, shrimp, apples, and exercising within that 2 to 4 hour time frame. But interesting enough, if you eat those foods and not exercise, you're good. So it's really, but that's also important, though, to think about in a history. Like, okay, this person had a reaction. What were they doing? Were they exercising? So on and so forth.
Now, but yes. They have then, so how would they present clinically?
No exercise.
So one of my patients, actually one of my buddies, he was telling me, he was just riding in Central Park. And all of a sudden, he was like, his foot started to swell. He just didn't feel good, start to hive up. And I was like, okay, sounds like you're having a reaction. He's like, okay, what did you eat prior? And he told me some of these foods. So if you have a kid that comes in and they say, oh, I was doing an exercise, I ate this food before, and I ate this food before without a problem, then you can think of this. And it's kind of hard to actually a gold standard diagnosis unless you give the kid food. I don't know if you guys have treadmills in the yard. You want to run around the office a bit and see what happens. Yeah, it's kind of interesting.
And what interval? How many hours before? 2 to 4. 2 hours?
2 to 4, yes. Yes.
Do they have a history of exercise-induced bronchospasm at all?
Oh, some people do not. Some people do not. Totally independent. There's some that do, some don't.
And do they have a history of food allergy, like separate from?
Some people, again, do, some people do not. Because, again, some people could eat those products without having a problem, but it's the exercise in that. I mean, sometimes it has to do with the catecholamines and the mast cell degranulation. We're still trying to figure that out. Okay. So just a time set of anaphylaxis, again, you could have the rapid onset. I just want to emphasize there could be a biphasic phase where your patients have a reaction, they get better, and it comes back, and that actually could be seen up to 72 hours. Then you have the protracted reactions where you're pumping them in with epi, Benadryl, this isn't getting better, ER, glucagon, all that stuff. And the people who are more prone to anaphylactic reactions are the young kids because they can't verbalize, you know, what's going on. Peanuts and tree nuts. I just want to emphasize, tree nuts actually produce more reactions, severe reactions, than peanuts. So I know everyone's on the peanut thing, but really it's the tree nuts that are the real culprits there. And again, if you have someone that has a known history of anaphylaxis, you know, that's another risk factor. And if patients have asthma, okay. Now, severity of prior reactions to food allergies doesn't mean the next time they'll have the same reactions. It could be milder, it could be worse. So you kind of can't use their prior reactions to say, oh, the next time will be great, oh, the next time will be terrible. So you have to treat everything individually. Okay, so I just want to go over some questions that should be asked during the history. How do I know if my child has a food allergy? The history is really important. You know, lab tests and skin testing are diagnostic tools for the history. So one thing you should ask is, what did the child eat before they had a reaction? Was it the common food? Was it a peanut? Was it a tree nut? Or was it something that was pretty benign, not causing a food reaction, such as rice or potatoes? Was this suspected food allergen ingestion, inhaled, and touch? There has been a lot of studies looking to see if cutaneous exposure, especially kids with eczema, can cause reactions. Did they eat it? Was it inhaled? Now, this is also very interesting. I had a lot of parents saying, my kid does not like to eat this food. Okay. And you got to figure out why. Is it because of the texture? Is it because they're not feeling good? So that's kind of, you know, something to pay attention as well. Try to tease it out of the parents. How soon after the exposure of the food did the symptoms occur? If the symptoms occurred 5 days later, maybe not a food allergy, maybe something else. What were the symptoms? Of course, if you have someone that had eaten 5 million, you know, M&Ms and they're just hyper, that might be because they're hyper from all the sugar and not necessarily a food allergy. And again, how long did it take for the symptoms to resolve? If it's taking more than a week, then we got to think of something else here. And did the patient have the food before? And again, does exercise precipitate the symptoms? Okay. So now that we got the history, a lot of the times people are like, okay, blood test, skin test. If my child does a positive blood test, what does that mean? They have a skin test, what does it mean? I just want to emphasize that both blood and skin tests are diagnostic for us in diagnosing food allergies. So both the blood test, the IgE against the food, and the skin test are very, very good at ruling out, but not so great at ruling in, okay? You have a 40 to 60% specificity. There's a high false positives with these things. And you also have to be careful with negative results because sometimes it's actually better to skin test with the fresh fruit products versus the non-fresh fruit products because those can elicit positive skin results. And we're now showing that a lot of the times certain foods such as sesame, there actually is a 40% false negative rate with those things. So again, you have to learn how to interpret these things. And positive skin test, again, doesn't equal food allergy. The size of the skin test nor the level of the IgE level does not predict severity. So I have some patients who have the IgE level of melt greater than 20. There are a large percentage of patients who have that level, to tolerate the melt, and they're good. Okay, so that's that. So, what's that? Exactly, that's the whole point, why do them? I mean, the diagnosis, the whole standard diagnosis for food allergies is a food challenge. I know some of our colleagues, well, my colleagues anyway, they get the history. If they think there is a legitimate food allergy, okay, avoid it. If they're not so sure, they do the challenges. Because it gets so confusing. You have all this data here, and we don't know what's what. So,
I think this is something which is worth a little bit more discussion.
Sure.
You know, we're under a lot of pressure.
Yeah.
Parents want kids to be skin tested.
Sure.
And many times you see skin test, which just means some sensitization, but not clinical allergy.
Exactly.
How would you advise the pediatricians to handle this pressure? Because really, we know academically we will tell them don't test unless there's a history.
Correct.
But then how do you practically, what is your advice?
Okay, so it depends on the patients themselves. If there's, I was going to discuss this later, but if there's like a known history of ACP, like eczema, or if there's a peanut allergic sibling, or if there's a history of asthma, okay, and you do this, I think at that point it would be a good idea to refer to us just in case we need to do the food challenges or we need to figure out how we need to address other food allergies in general. So any questions dealing with kids like that with the ACP, or if there is a family history of food allergies, it would be best if we see them. Because we can do the challenges in the office. It's not that long, you know, it's a half-day session. It gives the parents such peace of mind. They're not carrying around the EpiPen. They don't have to worry about the kid going on the school bus. And that's what I would recommend if there's any questions with that. Yes?
And how do you deal with the family, you know, who complains about half a dozen, you know, we see these patients, they're allergic to everything, and they're not related, they're completely figure run, you know, through challenges or, you know, because there's some parents, you know, who really want their kid to be allergic to everything.
Oh, absolutely. No, and those parents who have to explain, you know, yes, I see a lot of those kids, my kids are allergic to X, Y, and Z. I'm a big proponent of food challenges because the fact is you're giving them the food, we're in a setting, we can deal with it, we have the Epi, we have it all, and it's in peace of mind. You know, that would be one thing. And also you have to figure out what do they mean if I'm allergic? What does that mean? You know, that's the thing. If they have, you know, IgE-mediated stuff, yeah, that's fine. I know a lot of the parents about these intolerances and these sensitivities and everything, and that's really hard to deal with. I try to be very politically correct when I deal with them. I just say, listen, yes, there possibly can be sensitivity. The good news is this may not be the life-threatening reaction that we see in anaphylaxis. That gives some parents peace of mind. It's basically your relationship with the parents and how to enable the data and all that. But again, it's the gold standard diagnosis for food allergies is the food challenges. So
You have to be very careful in patients who have children who have eczema.
Yes,
because if you skin test them,
Yeah.
a lot of these skin tests are going to be positive, and some of them are, or most of them are false positive.
Oh, absolutely. So that's where you have to be very careful. And I'm going to talk about that when you should actually do skin test in eczema patients. Okay. Just going back to lab and skin tests, again, you need to interpret them with history. The stronger the positive reaction, the more likely a reaction is clinically relevant, and I want to just discuss what clinically relevant means. So there has been a plethora of studies looking at what IgE level and what skin test levels can produce a greater than 95% predicted value of a reaction, okay? And that means any type of reaction, whether it's just hives, whether it's anaphylaxis. It doesn't have to be strictly for anaphylaxis. And so these studies have come up with numbers to aid us, in helping us diagnose with food allergy. So I just want to go to milk here. So there's two categories, for young ones less than 2 and older ones greater than 2. And for cow's milk, when the IgE level is 5 for less than 2, there can be a 95% chance of having a reaction. For older kids, it's 15. When we do skin tests, when the wheel is 6 millimeters, again, for young ones, that might be a chance of reaction. For older ones, 8 millimeter. But these numbers are nice because if we're not so sure the history, or it may or may not, again, it's a diagnostic tool to aid us. But this is actually also important when we do food challenges, because the way that we monitor if a patient is quote-unquote outgrowing food allergies can be through IgE skin testing or IgE blood levels. And if we see that those levels are trending down, we might be more prone to do food allergy challenges at that point. Okay, so there is some benefit from doing this stuff. Okay. This is a great slide to have. If you guys want copies, I can give it, just because the levels and the cutoff.
I think the take-home message here is that if you have an IgE against the food or just above the noise level, it doesn't mean anything.
Exactly.
That's important.
Yes.
Because the computer just flags it as being positive.
Yes.
Oh, okay. So I'm a general pediatrician. Someone comes in to me saying, I think they're allergic to something.
Okay.
Having these hives.
Okay.
My take-home message is I shouldn't really be sending any RAS
Correct.
at all.
Correct.
Okay.
Yes.
The history is clear.
Yes.
I shouldn't use that as a quote, screening.
Exactly. You're absolutely correct.
So, and your use of these is basically someone who you know is allergic, and now it's been 3 years and they haven't had any reactions, and you want to test to see, well, maybe we can food test them. Let's see what their IgE levels are. They're below this level. Okay, I think it's probably safe.
Exactly. Exactly.
See. But so I don't have any use for this slide.
Okay. Okay. That's fine.
There's no reason for me to send it.
No worries. No worries.
Right?
Yeah.
I mean, I'm just.
No, it's cool. Yeah, no, I understand. Yeah.
No, I just want to be clear, because on the one hand you said don't send them. On the other hand, you say we should have a copy of this.
Well, if again, it's just. That's all. What's that?
He's got
plus
to everything.
I just thought it was just, it aids us, and that I just thought it'd be interesting if you guys wanted it. It's all good. It's all good.
So are you talking about the person who comes in with hives and you don't know? Like they have hives for no clear reason, or are you talking about?
Was there any reason for a general pediatrician to send a RAS whatsoever is the question?
Well,
and I'm getting from this talk that there isn't, because the results are going to be spurious and difficult to interpret.
Okay, so here's my question. If it's obvious, have peanut butter, had hives, they're allergic. So I would just prescribe an EpiPen?
Yes.
Okay.
And well, there is a chance, I just use milk as the example.
Okay, milk.
Sure, milk. Because the fact that sometimes children are with milk, they can outgrow it. These tests might help us to figure out when they're potentially outgrowing it. So again, it's a diagnostic tool. If we find that their levels, and again, this is more food challenges of milk, go below like 2, then we might say, okay, let's try the food challenge.
So I guess to contrast what Mark said is that milk, I know their reaction was to milk.
Sure.
I know it's like there's, on the one hand, say there's no value to me rat testing, but then again, if I know the reaction was to milk, shouldn't I just rat test them and do this documentation myself as opposed to, I mean, obviously, you know,
Well,
these IP patients.
Yeah, but if what happens, let's just pose the worst case scenario and say it's negative. You know, where there could be a chance it's negative, and then what?
So basically, we should refer all patients with a suspected.
No. For good cases where you want to do it, I think the question comes from the parent is when will they outgrow it, and how do I know they're outgrowing it? So that's where we might
Or if I have that kid that has a reaction, say, you know, maybe at 1 year old, 2 years old, I could just say a boy.
Boy for now, right?
So with milk, I could say a boy.
Right.
With, should I also say EpiPen, depending on their reaction? I mean, that's less with milk than with some other stuff, but.
I'm a big proponent in carrying an EpiPen because, again, you don't know what the next reaction can be.
So, okay, so say the kid has an EpiPen.
Yes.
Then when they come in at 5 or whatever.
Right.
And the mom wants to know, are they still allergic? Then I would send them.
That's fine. Yeah, absolutely.
Okay.
Yeah, no worries.
At what age would you say be more confident to parents, telling them 95% of the chance by this, you probably help outgrow?
Yeah, I have a slide on that.
Oh.
Okay, no worries. Okay.
That we can use that right.
What happened?
And then how hard is it to say, or you can't even have products that might have touched peanut oil, stuff like that?
Oh, that's again, the risk factors, if they're an eczema type of kid and they have a severe reaction, so on and so forth. I mean, there is, again, a lot of data saying that actually small exposures may be good. Yeah, so, yeah, there's a lot of good data on that. Okay, so I'm just going to get off this slide because it's controversial. It's all good, it's all good. And then I think this comes back to why do some patients have mild symptoms and others have severe reactions. And again, I think we all have to remember that you are reacting against the protein. And proteins have different structures. You have, I remember from biochem, remember the primary structure, and then the secondary, and then the tertiary and quaternary? Okay, so when the protein is presented in a sequential manner, and the IgE binds onto that sequential epitope, that could lead to more severe reactions. If the protein is globular, that could lead to reactions as well, but the nice thing about globular type of presentations is that they can be degraded through acids, through heat, through processing. And so this is the reason why some patients who can have raw fruits or vegetables per se, but if they have like apple sauce or apple juice, the protein's broken down because the IgE molecule isn't recognized it and we're all good. So again, preparation of food is interesting. So boiled versus roasted. It's very interesting because for peanut, for example, high roasting induces stability of the peanut versus boiled. In China, they do a lot more boiled peanuts and they have a less incidence of food allergy to peanuts. Emulsification through peanut butter, that process increases the stability of the protein product itself. Again, going back with the baked, cooked versus raw. Eggs, for example, some kids can tolerate baked, really cooked eggs, but then they can't have the raw. And again, it has to do with the epitopes that the patient has a sensitivity to. Okay, so I want to just go over this. This is actually the different epitopes that can be found in the peanut, okay? So there's a lot of epitopes that can produce reactions in peanut. So you have the RH1 and 3, which is part of a superfamily called the cumin family, and that's really important with seed storage. And people who have sensitivity to these two allergens here, they usually are more associated with the severe reactions, the anaphylactic reactions. Then you have the RH267 and the RH9. Those belong to a superfamily called the prolamines, and some patients can have severe, some patients can have mild. But look at RH8. This is the one that was associated with the birch tree pollen, and usually those patients, it's just the oral allergy syndrome symptoms with the peanut. So why is this important and why am I mentioning this? Well, it's turns out that one of the newer diagnostic testing that's available is this testing called component diagnostic testing, where we can actually test for the specific epitopes within the food allergen, and that gives us a good idea. Do you think this might just be a milder symptom? Does this mean that they'll have it lifelong, so on and so forth? So I'm just going to look at egg here. So egg has different allergens within them. You have the Galsy one, which is the oval mucoid. This one is heat stable and highly allergenic. People usually have reactions to this, versus the D2, the ovalbumin, the Gal3, conalbumin, which are more the heat vials, and those are the ones where people have sensitivities to those. They can tolerate the cooked, baked egg products. So West and I think LabCorp actually can do these things now. So if you have patients that have an IgE positive to egg, they could actually do reflex analysis to see what specific epitopes that's there. And if we find out that the patient has positive GALZ1, they might have a higher possibility of a reaction. It also might mean that they might have more of a persistent egg allergy. But this is actually important with peanut, because if you find that a patient just has an IgE against the RAH8, that means, oh, okay, maybe it's more of an oral allergy and not necessarily a anaphylactic. And this helps us, try to figure out what's what. But I just thought that was really interesting now that we're doing this. Okay. Now, if my child is allergic to the lobster, should he avoid all shellfish? And that's always controversial. Again, there's a lot of proteins that's shared between not only respiratory pollens, but can also be found in other food groups as well. So the peanut is not a tree nut, it's a legume, and there's other legume family members such as soy, beans, and lentils. But you see there's only a 5% cross chance of reaction there, versus the tree nut where there's a 37% chance of cross-reactivity. Fish, and the allergen to fish is something called parvalbumin. 50% chance if you react to salmon, you can react to other foods. The shellfish is pretty impressive. Shrimp, 75% cross-reactivity there, so that's pretty decent. Wheat is okay, 20% chance with other barley and rye. Milk is actually really interesting. People who are allergic to milk, there's a 10% chance they might be allergic to the beef itself, the meat. But look at this, 92% chance of goat's milk. So when you guys talk about alternative formulas or, food sources for milk, goat, not good, okay? Horse might be good. I don't know where. I don't know if they have it at Adams. I'm not too sure, but it is what it is. And then we have the pollen with the fruit, the latex we discussed here. Now I want to discuss this disease entity, and this is really interesting. That's just come about in the last year or so, and it actually has to do with an allergy to an oligosaccharide and not a protein. Okay. So this is the Lone Star tick, and this tick can actually bite up mammals such as cow, pig, so on and so forth. And when it actually ingests some of the products of these mammals, one of the things it ingests is this oligosaccharide called galactose alpha-1,3 galactose, alpha-gal for short. When it ingests that, it stays in the tick's alimentary canal, and then when it bites us, that oligosaccharide is presented to us, and we actually can display IgE-mediated reaction against this oligosaccharide. And so patients can present with delayed anaphylaxis to mammal ingestion. So that's really interesting. It's a new thing that's coming about. For those patients, unfortunately, you have to tell them to avoid all mammals. They can't eat it. So it's really interesting. So I guess they can go to the vegan route, but that's really kind of cool.
But the incidence is quite low.
It is low.
I haven't,
No, and it says it here. Right, and I don't know.
It's a hot topic, but it's very low.
Yeah.
You won't see it.
Where did they send it? Did they send it to National Jewish, the alpha-gal? I think it's National Jewish.
Yeah. Do you have information on cross-reactivity when someone's allergic to cow milk compared to almond or rice? Those are a lot of go-tos, almond and rice milk, for example.
Oh, okay. So it was cow's milk and almond and rice.
Usually they're cow milk allergic. They
Yeah.
say, can I use almond milk? Can I use rice milk?
You could try. Again, always try. Yes. I don't have the data on that. I apologize. I'll get it for you. Okay. Okay. Okay, so this goes back to your question, my friend, is will my child outgrow his food allergies? Now, if they're usually allergic to milk, eggs, soy, and wheat, yes, they will eventually outgrow it. I think we're very familiar with kids outgrowing them at earlier ages, 5 to 6. Unfortunately, we're now finding that a lot of these kids are outgrowing allergies later on in their teen years. And that actually has a lot to do with a couple things of what epitope they're allergic to, if they have an atopic history, so on and so forth. Fewer children have resolution of peanut or tree nut allergy, and I want to talk about peanut. So 20% of the time people can outgrow peanut allergy, and when they do, there's actually a high reoccurrence rate of it coming back. And this has to do with what Dr. Sharma said, low-dose sensitization. If you technically outgrow an allergy, you're supposed to have a little bit of that food every day to maintain tolerance. And if you don't, unfortunately, the immune system might be skewed again to the IgE-mediated reaction. So for some patients who technically have outgrown their peanut allergy, you got to take a little bit every day, and if you don't, then it could come back. So there's a lot of hot data looking at the induction of low-dose allergen exposure every day. Okay, so COVAR, which stands for a Consortium of Food Allergy Research, had tried to come up with an algorithm to see when the patient will outgrow their food allergy. And this is based on observational studies done at Mount Sinai, all over the world. And with milk allergy, they looked at 3 components with children. They looked at the milk IgE level, the skin test level, and if they had atopic dermatitis. So I put this kid, their IgE level is greater than 100, their skin test is 20, they're terrible. So they figured out when they become 6, only 40% or 30% of them will actually outgrow the allergy. Versus that sliver, the IgE level is pretty low, the skin test level is pretty low, no atopic dermatitis. You can see by age 6, close to 100% of them will outgrow. And this is a great kind of tool to aid us to figure out this is when the kid will outgrow it. Just remember, it's just a tool. It's not set in stone. Okay. So going back to, does food allergies cause eczema? I think everyone's aware eczema is a pretty tough disease entity. It's mediated by a couple of factors. There's their skin function. We now know that a lot of patients have mutations in certain genes in the skin can present more with eczema. Unfortunately, these patients are more prone to infections, whether it's antibacterial or viral. And these patients just like to produce a lot of inflammatory cells, causing more eczema to occur. And again, it's a combination of an IgE and cell-mediated reaction. So it is very controversial at this point stating if foods can exacerbate eczema. Some studies say yes, some studies say no, so it's controversial. But I just want to go over what our academic board recommends with food testing and eczema patients. So according to our expert panel, food testing should be considered for children less than 5 with moderate to severe persistent atopic dermatitis for the following. If their atopic dermatitis is not controlled through emollients, steroids, you've done everything you can to control it and it's not getting better, then you might think of food issues. Or if these atopic patients have had a history of IgE food reactions before. Those are the only times where you should consider testing for food allergies. And what you test for is really based on the history again. You shouldn't recommend extensive elimination diets based on positive skin tests or blood tests because of the risk of nutritional deficiencies with these kids. So this is what our academic board formally recommends as food allergies and eczema. Oh, at any age, yeah, any age.
We see a portion of 6 months into pretty severe eczema, which often improves significantly by 3 years. So you would still refer them.
If you can't get it controlled through technique, again, through medical management, through family history, yeah, definitely. Okay. Okay, so a lot of the times parents come in and they want to know, is there anything I could do to prevent food allergies for My baby, okay. So maternal diet should not be restricted. You can tell the mom to eat anything, of course moderation is the key, don't go overboard with things, but during pregnancy and lactation. Now, it's also recommended by the AAP that infants should be exclusively breastfed until 4 to 6 months unless there's a contraindication. There's actually a lot of conflicting data as to see if it does help prevent food allergies, asthma, atopic dermatitis. Again, some studies say yes, some studies say no. Now, there are also some studies showing that the use of extensively hydrolyzed formulas versus cow's milk formula in at-risk children, again, children who have atopic dermatitis and family history of allergies, that can actually help prevent the development of cow's milk allergy for kids that are not exclusively breastfed. So that's something that we can also do as well. Okay, so when should I introduce the allergenic food? So, again, insufficient data to document the protective effect of any dietary intervention beyond 4 to 6 months, okay? So I know there were some older school theories that you should wait like a year or so for eggs, peanuts, so on and so forth. Not necessarily the case, 4 to 6 months. Again, I wouldn't, give peanuts to the kid right away, and use your clinical judgment. But it's also very interesting because there was this great study by Dutoit who looked at a cohort study of Jewish children in the UK versus Jewish children in Israel and when peanut was exposed. And basically, as soon as the kid was born until 1 year of age in the Jewish cohort, there was peanut exposure every day. And in the UK study, there was not. And they found that there was actually a statistically significant decrease in food allergies for children that were exposed to peanuts versus who were not exposed. And that goes back to your point how a little bit of exposure is a good thing. Dutoit is also trying to look at other studies. The EAT study is the eating about tolerance study, looking to see about different types of foods and when food introduction can be due and the immunological suppression from that. So there's a lot of good studies that are occurring right now. A lot of the times parents ask, okay, when do I give these allergenic foods? When do I do this? Well, better to be safe than sorry. Home is better than the daycare in the restaurant. That's just not a pleasant experience for anyone. Taste first, just put a little bit on the lip, and if you tolerate that, give a little bit more. Again, just, common sense stuff, introducing one food at a time every 3 to 4 days. And it's also really interesting, some foods, like peanut, can cause a reaction upon the first exposure, so you have to make parents aware of that as well. So that's something to think about. Okay. So this goes back to the question of when should the patient maybe refer to us about introducing potentially allergenic foods into their diet. Well, these are some of the scenarios where you might want to consider a personalized plan for a food introduction. Peanut allergic siblings, they're more prone to have peanut allergies, so sometimes what we do in the office is we actually do the challenges right there and then. Again, children with one underlying food allergy, there's this LEAP study. The LEAP study is learning about peanut allergy, and we're finding that patients who have eczema and egg allergy are more prone to have peanut allergy as well. Kids who have moderate to severe eczema. And again, children who have had clinical reactions but have negative skin tests or blood tests. So again, we need to figure out when we should introduce what. Okay, so a lot of the times, I get this a lot, I'm sure you guys do too. Okay, this food may contain this, may have that. So the FDA had come up with this act, the Food Allergen Label and Consumer Protection Act, or FALCA, that they looked at the 8 most common allergenic foods, the milk, egg, fish, shellfish, tree nuts, peanuts, wood, and soy. And they state it has to be clearly labeled on the food product that's made in the U.S. and also imported as well. It has to be in bold text, or it has to say the contains. Now, look at the exceptions. They don't have to do this with oils. So for the most part, soy oil can be tolerated, corn oil as well. Peanut oil is very interesting because refined peanut oil in the U.S. doesn't really have a lot of the proteins in it. However, there's this other type of peanut oil, expeller pressed peanut oil, and that actually has the protein in it. And unfortunately, the labeling doesn't distinguish between if it's expelled pressed or highly refined. Sesame oil does have a lot of protein in it, so I would avoid sesame oil. So those are the things as well. Now, sorry? Butter oil? Oh, because of the dairy?
Yeah.
They didn't have any recommendations on that. I didn't see any studies on that. I'll take a look though.
What is your recommendation?
About butter oil? It depends again. Just again about the severity. I mean, if it's a mild severity. Yeah, if it is again, it's based on the history itself, that there's like atopic, maybe avoid. If their history, if there's reactions were bad, avoid. I really haven't seen a lot of reactions with butter oil, to be very honest with you. Yeah, yeah. So a lot of the things that a lot of parents have the question is these precautionary labels may contain made in the same facility, manufactured in the same equipment. That's not regulated by the FDA. It's actually voluntary. And it's really interesting because there were studies done looking to see the amount of food allergen exposure with labels that may contain egg versus labels that don't contain the allergen products. And they actually found that some products that have no label whatsoever have had positive concentrations of potentially allergenic foods, and those that don't have, that have a label, they actually didn't have anything. So it's really.
So Paula, what do? Do you tell them to avoid or no?
Well, it says to avoid. My thing is if they've had it before, they're good. I'm very wary, though, about the share in the same equipment. That's where I get very concerned about. Because look at the facility. If the facility is the size of After and you have the peanut at one end and whatever, chocolate at the other end, it's very unlikely. I will say this, the FDA is trying to gather more data on the concentrations of the food that can be exposed. So that's something to come about. But again, it's going to be patient-specific on what you tell them. That's the only recommendation I can give at this point. Okay. Again, treatment for food allergies, unfortunately, it's avoidance at this point. Allergy action plans are really important. I give them out to the parents, grandparents, whoever's watching in the schools, everything, education about food allergies. The medical alert bracelets are really, really important, and they're really cool ones out there that the kids really like. The epi. So it is very important for these children to have 2 epi auto-injectors with them at the same time, not just one. And I know with the insurances, they will cover just the one box and the parent splits them up. They give one to the school and one at home. The way you deal with that is that you put refills. And basically you tell the parent to go back next week, refill it, and get another one the next week and refill it. So there's more boxes to be spread around. The reason why we need 2 is this, is as soon as you give the epi in the leg, you know, things could get better after 5 minutes or things are not getting better. 40% of the time, people will need an additional epi dose in the other leg, so that's why it's important to have 2 rather than 1. There's some patients that even need 3, so it's really tough, but 2 is the minimum, and that's how I kind of go figure it out with the insurance companies. Just tell them to get the refill, so on and so forth.
Something called the EMS, you know.
Oh, yes, yes. Oh, sure. Right, but unfortunately, just because of this area, sometimes there is a little bit of lag time, you know, for the EMS to get to the house, you know, may not be as quick as, you know, if someone lives right by Baxter. You know, some of these parents, they live in, wooded areas. It takes time. So it's really important to have those. Future treatments, they're doing a lot of good studies, especially at Sinai in the city, looking at oral sublingual immunotherapy, Chinese herbal medications, anti-IgE. But again, nothing in the woodwork now, so it's just avoidance. And that's my little niece, Olivia. And thank you for your time. Thank you.